because the topic that we are considering today of vaccines and their role in public health in India is a critically important one. The way I have structured this presentation is to have an outline that talks about the impact of vaccines, talks specifically about challenges in India, and then looks at what the future of vaccines might be, both in terms of the development of new vaccines and also what we should be doing in terms of outbreaks and global responses to emergencies. Now, we are all familiar with what the world was like without vaccines. Just as an example, I can tell you about smallpox. If you look at the 1700s, when the population of the world was much smaller than it is now, almost 400,000 people died every year of smallpox. And then at the end of the 1700s, Edward Jenner did an experiment where he developed essentially a vaccine that was based on a different virus, the cowpox virus, and showed that infection with that agent could prevent people from getting smallpox. Now, this was remarkable because it was the first example of a heterologous antigen protecting from disease. After Jenner showed this experiment, and Benjamin THSTI had done it a little bit earlier, by 1800, vaccines for smallpox were being given all across Europe and North America. In 100 years, smallpox had been eliminated from the industrialized world, and people began to think that if it was feasible to do in some parts of the world, it might be possible to eliminate smallpox from all of the world. In the 1950s and the 1960s, there were a number of programs that were undertaken by the Pan American Health Organization and the World Health Organization that intensified the efforts to control smallpox. And finally, in 1979, WHO was able to declare smallpox eradicated. Now, this is the first and so far the only example of a human disease having been completely wiped out by a vaccine. Now, this is what vaccines did for one disease, wipe it off the face of the earth, but in other cases as well, when vaccines are introduced, there can be remarkable reductions in disease. If you look at the slides here, these are data from the United States and New Zealand showing what happened when a measles vaccine was introduced in the US and when a meningococcal vaccine was introduced into the immunization program in New Zealand. Measles had been a long-standing disease, and a good vaccination program was able to practically eliminate measles. For meningococcus, this was a vaccine that had come into prominence in New Zealand only in the 1990s, but it was uncontrolled without the advent of vaccines. So vaccines can eradicate disease, vaccines can control disease, and it has been estimated that vaccines are probably one of the best investments in health that people can make. The WHO estimates that vaccination currently saves between 2 and 3 million lives a year, and generally vaccines go way beyond just saving lives and improving health. Vaccines are an investment that have wide benefits that can accrue over a lifetime. What do I mean by this? Vaccines, when a child is sick or an adult is sick, essentially it means time away from work for them. If they were vaccinated and the disease was prevented, then a child's illness results in a parent's ability to work more. Children who are not sick can go to school, they receive a better education, and that improves society for everybody. So if we examine the value of health, health actually contributes to our income. It increases productivity, it increases our ability to get and impart an education. It allows us to invest in a demographic dividend. But income also contributes to health. With nutrition, safe water, sanitation, healthcare, including preventive healthcare, such as vaccines, we can assure a better health for our people. It's been estimated that a 10-year gain in life expectancy translates into up to 1 additional percentage point of annual growth of income per capita. So when we argue about whether India's annual growth is 6% or 7%, just imagine what the value of improving health for our people might be. A lot of people have not paid attention to the full economic benefits of vaccination. More recently, there have been attempts to address just how important vaccines can be for maintenance of health and the prevention of disease. In India, this is still something that we do insufficiently, and we should be focusing in this area. If you take what is usually done, the narrow perspective of the value of vaccines focuses on the direct savings to healthcare and also to care-related productivity gains. So where you are not investing in care, what do you get instead? However, if you take a broader perspective of the value of vaccines, then that relates to outcome, to behavior, what happens to communities that are healthy, communities that are economically productive, and what a reduction in the risk to such communities can possibly mean. So if you look at this slide, it's a complicated diagram, and I'm not going to go through all of this, but capturing the value of vaccines through various ways of getting information is being increasingly recognized and is something that we need to be thinking about. Now, moving on from the impact of vaccines to challenges in India, we know what the WHO has said, that immunization currently averts 2 to 3 million child deaths a year. However, what it leaves out is that an additional 1.5 million deaths every year could be avoided with better vaccine coverage. So approximately 20 million children across the world are still missing out on basic vaccines, and India has the most unimmunized and incompletely immunized children in the world. If you look at the causes of death across the world, India contributes about 20% of all child mortality. So even though 1 in 6 people in the world is Indian, among those who die as in childhood, 1 in 5 are Indian. Could any of this be prevented by vaccines? Yes, some of these deaths can be prevented. Shown in this figure are the causes of under 5 child mortality in India, and shown alongside are the various ways in which vaccines could prevent some of that mortality. Not all, but some. It is possible that neonatal tetanus can be prevented, and in India we have currently maternal and neonatal tetanus elimination. Measles vaccines are very important, not just for prevention of measles, but also for subsequent infections. And then pneumococcal, Hib, measles, and pertussis vaccines all contribute to a reduction in pneumonia. For diarrhea, we have both rotavirus and cholera vaccines, both of which are being insufficiently used in the country. Nonetheless, There have been success stories of vaccines in India. If you look at smallpox, it's gone. There was a global eradication in the 1970s. Polio is gone from India. Our last case was in 2011. We have had maternal and neonatal tetanus elimination. After the second dose of measles was introduced, the number of cases of measles have declined. Diphtheria had become less than 3,000 cases per year, but last year, unfortunately, because of reduced coverage, we had outbreaks in Kerala and in UP. And pertussis we have reduced by 86% in the last 20 years. Now, in India, if you look at the size of the program, the scale of what we do is phenomenal. Our routine immunization program targets 26 million children every year and 30 million pregnant women. There are 9 million routine immunization sessions organized in India each year. We need 27,000 cold chain stores to manage this. The national average currently for full immunization is 61%. For DPT-3, it is 72%. When we run a National Immunization Day, as we did earlier this month, 172 million children are immunized for polio, and our campaigns cover 800 million children a year. A 3-year campaign to ensure that children get the second dose of measles vaccine targeted almost 150 million children, and now we are doing a measles rubella campaign that will run through this year and next year. The numbers are phenomenal. The scale is incredible. We have had, however, a focus that has been restricted so far to childhood vaccination and to maternal tetanus. We really haven't had a life course approach, and sometimes perhaps the challenges are too big for us to be thinking about that. But there are vaccine preventable diseases that are important public health problems like typhoid or cholera, where we need to be thinking about what we can do. If you look at the program itself, there is a huge heterogeneity in the program. If you see here, what is given in the graph is the performance of different districts for different kinds of vaccines, and you can see that there is plenty of room for us to improve. In addition to this, we need to think about what kinds of approaches work best, whether it's routine or vertical programs like we've had for polio, or the mission Indradhanush, which is a periodic intensification of routine immunization. Nonetheless, despite the fact that we have so far reasonable but insufficient rates of coverage, we have begun to introduce new vaccines. Pentavalent vaccine is now available countrywide in the public health immunization system. Japanese encephalitis vaccines are being given in target districts. Rotavirus vaccines were introduced in 4 states last year, and 5 states are planned for this year. Pneumococcal vaccine will be introduced this year in Bihar and possibly UP. Human papillomavirus vaccines have been introduced in Punjab, and other states are thinking about introduction as well. So with the size of India's birth cohort, people say we add 1 Australia every year to the population of India. We need to be able to prevent disease and to promote health. And in doing this, vaccines and the vaccine companies that make these vaccines are key partners in our ability to deliver vaccines to our children and globally. I'll move briefly to the story of an Indian rotavirus vaccine to illustrate how the Indian vaccine industry is good for global public health. Group A rotaviruses are the most common cause of dehydrating diarrhea in children. Because rotavirus causes both vomiting and diarrhea, children can become dehydrated in a matter of hours. And this means that the potential for them to die is very high. In India, we began looking at rotavirus in the late 1970s, and in 1985, an outbreak of rotavirus was identified in the All India Institute of Medical Sciences by Dr. M.K. Bhan, a pediatrician who worked there. He began to think about whether this could actually be a strain that could be used for a vaccine. And he spoke to some people in the Department of Biotechnology and at the National Institutes of Health, and they supported through the Indo-US Vaccine Action Program strain characterization in the US and in India. And they made pilot lots of this vaccine candidate, which was licensed to an Indian company, Bharat Biotech International Limited. This vaccine was tested in India in 3 sites and was shown to be about 55% efficacious. This is the vaccine that has now been introduced into the program to address the rotavirus disease burden in India. If you look at what the burden is, 1 in every 2 children in India will have a diarrhea. 1 in 8 children will need to go to an outpatient clinic. 1 in 30 children will be hospitalized due to rotavirus gastroenteritis. And 1 in about every 350 children will die of rotavirus gastroenteritis. This is the burden that the vaccine seeks to address. This is the vaccine that was introduced first in Himachal Pradesh and subsequently in Orissa, Andhra, and in Haryana. Now it has been introduced into Manipur and Madhya Pradesh as well. India is the first country to introduce this vaccine and say that this vaccine can be given up to 1 year of age for the first dose. We are currently doing studies that are going to measure the impact of this vaccine introduction into India, and this is the first time that an impact assessment study is being undertaken for a newly introduced vaccine in the public health program. Just to summarize, the vaccine is one that is made by an Indian company for India, and the company is now looking at whether WHO will allow this vaccine to be used around the world. This vaccine is now in 6 states, and there are more states to come, but this vaccine has the potential to save 30,000 children's lives every year. Of course, there continues to be work to be done. I mentioned that this vaccine has 55% efficacy. So are there ways that we can improve its performance? In addition to that, monitoring the impact of the vaccine and the safety of the vaccine will continue to be important. Moving finally to the future of vaccines, the valley of death for vaccines is because people have ideas, but it takes a lot to develop a vaccine product. There are many new strategies that are available for vaccine development, a number of platforms for which vaccines are being tried out, and these extend way beyond the traditional infectious diseases into cancer and autoimmune diseases for which we might be able to think about both therapy and prevention. However, if you look at why vaccines are not made for many of the things that we think are preventable, the reason really is cost. You have a target antigen identified, it doesn't cost very much. Do a preclinical study, still doesn't cost very much. You do a proof of concept in animals, should still be okay. But when you move into human testing, that's where the costs really escalate and small companies become scared to take on such issues. The costs also go up hugely the more you move to the right of this graph. On the other hand, if you look at the probability of success, the probability of success goes over 60% only when you are in phase 3 studies. So one thing that we need to be thinking about in India is, can we think of a new paradigm for testing vaccines where you actually left shift the curve and try to make vaccines fail earlier rather than later. This would allow us to test many new vaccine candidates and also decrease the costs of developing such candidates. So how do we left shift vaccine R&D? Basically, it takes a very, and there are many reasons why this happens. There are very few animal models available, and if they are available, they may not reflect human disease. Sometimes it's difficult to understand how vaccines work because we don't have the physiologically relevant studies that we have done. There is a difficulty in defining correlates of protection, because if you have a correlate of protection, then just by measuring an immune response, you could think about licensing a vaccine. And then finally, strategies to up-select or down-select vaccine candidates in an affordable and timely manner really don't exist. However, if we could think about putting antigens into people at an earlier stage, that would allow us to do exploratory clinical studies that would address many of these issues. But of course, there are major logistical barriers to clinical research in India. We can think about then a different kind of paradigm where we go early to humans, but as I said, this is something that we are beginning to think about as a new model for vaccine development, which does not currently exist. The traditional way of going from a small animal to a large animal to a human is the way that all vaccines have been developed so far. Now can we think about early stages of human testing as an alternative? So what are these early stage studies that can be done? These are small studies done in volunteers. They include a group that is called controlled human infection models. Essentially, it's a volunteer study. Now, why do I bring this up as a way of thinking about vaccines? And this is really because controlled human infection models are being used now to develop vaccines, but they are not being used in India. These have been available for more than 70 years. About 6,000 people have participated in a variety of diseases. And where they have been used, they have been tremendously informative to the process of developing new vaccines. These are some of the areas where such studies have been done: for influenza, for typhoid, for malaria, for toxigenic E. coli, cholera, Campylobacter, a range of different pathogens where people have actually volunteered to take part to be artificially infected by an agent and then to have that infection prevented by a vaccine. So moving from the idea of developing new vaccines more quickly brings us to outbreaks and global response. Now, everybody is familiar with the story of Ebola last year. Ebola came in and 28,000 people died. We actually now have an Ebola vaccine. We did not have it before the epidemic started. And why was that? That was because lots of people had candidate vaccines, but those vaccines were sitting in freezers in different parts of the world because, as I mentioned earlier, it's very expensive and takes a long time to develop a vaccine. However, when Ebola came around, WHO, the CDC, the National Institutes of Health, people in the UK decided to coordinate efforts to take some of these vaccine candidates out of freezers and into the field to see if they worked. The problem was that it took such a long time to get all the permissions to test these vaccines out that the epidemic was dying by the time the vaccines were actually tested. So this just shows you in the shaded area when the vaccine trials were actually started and when they were completed. As you can see, the bulk of the cases, vaccination was initiated on the 23rd of March, but most of the cases had already taken place long before that. Had we been able to get permissions to start the testing, let's say sometime in August of 2014, we could have done the vaccine trial and been able to abort this particular epidemic much faster. So essentially to say that a 6-month decrease in the time frame would have allowed us to have a vaccine earlier. There were ultimately 15 vaccine trials that were conducted for Ebola at various points in time. Only one of those trials was ultimately able to produce the data that demonstrated that anybody who had got the vaccination immediately after exposure did not develop disease, whereas people who had a delayed vaccination 21 days after they were exposed did develop disease. So this is a vaccine which has 100% efficacy. If we had had this vaccine before the epidemic started, 28,000 people did not need to have died. So in order to address such issues, people have begun to think about what it takes to do timely vaccine development. Just in case an outbreak happens, can we have a response speed that allows us to use vaccines quickly? There are many platforms that are available now for making vaccines, and in some of them, it is possible to make vaccines very quickly. Right now, the NIH has been able to make a vaccine in 3 months from getting the sequence of the infecting agent. In India, we are very far from doing that at the moment, but we are beginning to work with global partners. Now, globally, the WHO and other agencies have organized lists of agents that they think have a very high chance of causing outbreaks. These include Ebola, Nipah, which is a virus that comes from bats and has been reported in Assam and in West Bengal, Zika, which everybody knows about, chikungunya that people are all aware of after the outbreak in Delhi last year, but a range of other diseases that are all present in Africa and South Asia. In order to address these, the government of India is participating in an initiative called the Coalition for Epidemic Preparedness Innovations. And the idea here is that this group called CEPI is going to stimulate, finance, and coordinate rapid vaccine development against priority threats for areas where vaccine development is not going to happen because the big companies will not make them because they have no market incentive. So where outbreaks happen usually is in the poorer parts of the world, and these are precisely the people who cannot pay for new and expensive vaccines. So the idea of CEPI is that we will be able to do something together to protect people in such regions when outbreaks happen. This is a partnership between CEPI and WHO who will work together to identify the agents, and CEPI will move vaccine candidates that are currently in freezers to proof of concept and safety in humans before the epidemics begin. That means we can have stockpiles that are available for potential emergency use. In addition, we'll also be looking at platforms that can be rapidly deployed when you have a new and unknown pathogen that causes disease. So CEPI's role is really to fill the gaps in the production of vaccines for emerging infectious diseases where industry is not usually interested. In India, there has been leadership in the founding of CEPI, and we will continue to be able to work with them and with the Indian vaccine industry to make this happen. Finally, to summarize, vaccines are a clear best buy for public health. In India, we have implementation challenges and development challenges, particularly where clinical research is concerned. Taking on new vaccine development offers opportunities for the advancement of science in India, Indian vaccine industry, and supports public health. There are exciting and interesting new areas of experimental medicine and platform technologies, but these have many hurdles. If we can overcome these hurdles, the possibilities are immense. Thank you very much. I'd like to leave you with the thought that currently 2/3 of the world's children receive at least one vaccine that is made in India. This is a fact that is not recognized in India or elsewhere, but I think it is one that we must emphasize, particularly during the World Immunization Week. Thank you.
So let's start with the questions. The first question is from Neeti. How do you think GOI can help us to prevent high mortality rates by introducing new vaccines as part of immunization program?
I think the government of India, I think I pointed out in my slides the scale of what the government of India does. No other country in the world has an immunization program that is as large as the Indian immunization program. So the government has been trying to do what it can. The way the government system works is uneven. Some states are much better than other states. So there have been FY routine immunization in the poorer performing states and the poorer performing districts in the well-performing states, both in terms of being able to reach children and in the ability to deliver new antigens to children. The government is trying, but there is still a lot that we can do. The rotavirus vaccine will be rolled out hopefully across the country. Pneumococcal vaccines are going to be introduced and hopefully will be expanded. But there are many other antigens that Indian children do not receive that children in developed countries do receive.
Next question is from Vibhu. Now with three different completely rotavirus vaccines available in Indian markets with completely different rotavirus strains, are there any fallouts?
So currently the two vaccines that are made by GSK and by Merck are used only in the private market, and the Rotavac vaccine, which is made by Bharat Biotech, is used in both the public and the private market. These vaccines have been in use. All three vaccines have been available only for the past year. Previous to that, only Rotatec and Rotarix, the Merck and GSK vaccines, were available. It's too early for us to say what the fallout of the use of these vaccines is going to be. We are certainly doing an impact assessment study that will show what happens with vaccine introduction. It's unlikely that with the Merck and GSK vaccines, There are sufficient numbers of vaccinated children for us to be able to measure impact, but there will be with the Rotavac vaccine, which is being made by Bharat Biotech. I also agree that all three vaccines are completely different from each other, but we do have data on impact of the Merck and GSK vaccines from other countries. For the Rotavac vaccine, this is the first time that there will be an impact study being done.
Next question is from Geeta. When a disease is eradicated, then how and why are cases like diphtheria coming up again? Does it mean we are not going to the root of it?
Okay. So there are two reasons why a vaccine cannot completely get rid of disease. One is you don't give the vaccine to everybody, right? So if everybody is not vaccinated, there will continue to be some susceptible people in the population. And when they are exposed to that disease, they will get it. So what happens frequently is that when people have not seen a particular disease for a while, they say this disease doesn't exist. Why should I immunize my child against it? This is what happened with measles in the US. So you don't immunize your child because you think giving antigens to your children is something that is, you want to try and protect them from receiving too many antigens. And then you take your children to a public place where somebody has measles and you acquire measles and it sets up an outbreak in your community. So children have died in the US because of measles. So vaccinating people is very important. So one is you must vaccinate people, and the second is the vaccine must be 100% efficacious, which all vaccines are not. So if a vaccine is not 100% efficacious, you don't eradicate disease. Specifically looking at the diphtheria outbreaks in India, there were actually two interesting patterns to diphtheria in India last year. One was disease in Kerala. And the disease in Kerala was a disease of young adults. What happened there was people essentially did not want to vaccinate their children. They didn't vaccinate their children. The children grew up, became young adults, were exposed to diphtheria and got sick. And diphtheria is a killer disease, as people who have been around in the times before vaccination know. The other pattern that was seen was actually in the sporadic disease that was seen in UP and Bihar, and there it was in younger children. And if you see disease in younger children, that disease tends to be that these children were reported to have been vaccinated, but the quality of the cold chain can be questionable, which means that the vaccine may not be as efficacious as you would expect it to be. So when you see disease, you need to, or a vaccine preventable disease, it's important to look at the pattern of the disease, the age group that it's affecting, the geography within which it's distributed, in order to understand what is failing, whether it is the vaccination system, the vaccine, or the people that refuse to take it.
Next question is from Dr. Anil. What is the strategy or plan to monitor the potency of vaccines being sold in the market, especially given the power cut across India?
So usually all vaccines that are in public health systems are best provided with a vaccine vial monitor that looks at temperature excursions and changes color when the temperature has gone beyond the level that it is permitted. There is a protocol in the government that when there is a vaccine vial monitor, they are supposed to look at the color of the monitor as well as look at the content of the vaccine vial before deciding whether to give it or not. Now that is the public health system where there is some level of monitoring and reporting. However, a significant proportion of vaccines in India are delivered through private practitioners, and private practitioners very rarely have a vaccine fridge to store their vaccines. Usually they store it in a domestic refrigerator, and the point that's made about power cuts is very valid. So if there is a temperature excursion, people will not know about it, and the vaccine being given will not produce its intended effect. Now, this monitoring does not happen in India. The only situation where monitoring might happen in a private setup is as part of a survey, or if there is an adverse event following immunization that is reported, in which case the vaccine vial will be taken and the potency of the vaccine will be evaluated at the central laboratory in Kasauli.
Next question is from Shubhendu. What can galvanize the private sector in India to have a greater traction compared to pure play pharma players?
I'm not sure I understood that question completely, but just to speak about the role of the private sector in delivery of vaccines. I think the private sector reaches people that the public sector cannot in many ways because, if you are working parents and the only time that you have free is on weekends or in the evenings, where do you get your child immunized? You take them to a private practitioner. And private practitioners therefore fulfill a huge function. Now, where the government should be helping private practitioners is that when the government has a responsibility to deliver certain routine vaccines to all children, the government should provide those vaccines to be given by private practitioners at their clinic with an administration fee or whatever they want to charge. But private practitioners who deliver vaccines also have a responsibility to the government, which is to inform them of which children they have vaccinated with which vaccines and report any safety events that occur. So for the government to maintain records of immunization of children is very important and cannot be fulfilled if private practitioners don't report their data. Similarly, some vaccines have side effects, so reporting those side effects on the part of private practitioners is very important. Now, coming to the relationship between private practitioners and companies. Now, this is one that is a very, very contentious issue because vaccine companies want private practitioners to use their products because they make a profit when they sell their vaccine to a private practitioner. But the decision on the delivery of that vaccine to one child or to all children in a practice is one that the private practitioner makes. Now, most vaccines prevent disease that are important for that particular child. But sometimes these vaccines are also expensive. So how do you decide whether you want to spend 3,000 rupees or 5,000 rupees giving your child a vaccine for which there is only a very small chance that your child might develop that disease? It doesn't matter at all to a rich parent, because for the rich parent, prevention of disease in their children is important. What if it's a poor family that has to borrow money to get that vaccine for its child? Now here there is a responsibility of the private practitioner to discuss with the parents what is feasible and advise them appropriately, keeping in mind the interest of the child and the family and not of the company that has asked him to sell those vaccines.
Next question from Dr. Naresh. Are we likely to see PCV inclusion in the national schedule soon?
Yes. PCV is going to be introduced in Bihar and UP first, but we hope that PCV will be introduced across the country soon. Currently, we don't have an Indian manufacturer of PCV, so it is going to be a very, very expensive vaccine for us to buy. Some of the money will come from Gavi support, but there are Indian manufacturers that are developing their own PCV vaccines, and we hope that those will become available soon and those will be more affordable for the Indian public health system.
Next question from Shubhendu. In the slide on left shifting R&D shown, time can be compressed but cost remains the same. So how is the cost component justified?
The cost component is justified by having more early failures. So essentially, if you take 10 vaccines to phase 3 and they fail, having those same 10 vaccines fail in preclinical or in proof of concept studies will cost significantly less. So early failures are better, faster, cheaper.
Next question from Niti. Do we have or plan to have any vaccination programs for adolescent and adult immunization?
For adolescents, the Punjab government has already introduced the human papillomavirus vaccine, and there is huge interest from other states in introducing the same vaccine because cervical cancer is still one of the biggest killers of women in India. In addition to HPV, there is also potential for introducing other vaccines for adolescent health, and we will be looking at that, but right now the priority is HPV. For adult immunization, we should be thinking about other vaccines. We should be thinking about other vaccines in pregnancy because currently we give tetanus toxoid, which we are replacing with tetanus diphtheria. But we could be thinking about an acellular pertussis vaccine to protect infants in early life from whooping cough. We could be thinking about influenza vaccines on a larger scale. We could be thinking about pneumococcal vaccines for the elderly because respiratory disease is a big killer of elderly Indians now.
Next question is from Dr. Srinivas. What surveillance measures have been set up to detect adverse effect following the introduction of rotavirus vaccine in the 4 states since the vaccine is being given till 1 year of age?
Okay. So before the vaccines were introduced, there was training of trainers, and it goes all the way down the vaccination program, telling people about what they should be looking out for. So for rotavirus, vomiting, diarrhea, and intussusception are the things that people need to be looking out for. And these were informed to all of the staff who do this. In addition to that, there has also been surveillance set up in all of the states that have introduced vaccine to identify cases of intussusception. Now, as you're aware, intussusception occurs in the absence of rotavirus vaccination as well. So what we hope will happen is not only will cases of intussusception that are associated with vaccine be picked up, but also cases of intussusception that are not associated with vaccination will be picked up earlier and managed better. Through this sentinel surveillance that has been set up for intussusception, we hope that by the middle or end of 2018, we should have reasonable figures for intussusception in the states that have introduced vaccine and be able to demonstrate whether there is or is not an association with vaccination.
Taking our second last question. This question is from Dr. Sumitha. There have been reports of pertussis outbreaks in some states of US. In your opinion, do you think something similar is possible in India?
I think for diphtheria, pertussis and tetanus, if we stop immunizing, the diseases will come back. People don't realize this, but the US is a clear example of that. Pertussis is there. They actually see some cases of diphtheria as well. They don't and never have had a lot of tetanus, so it's not surprising that they don't see it there. Plus, they also immunize the mothers. So pertussis outbreaks in the US are happening because of lack of immunization and also because they switched to the acellular pertussis vaccine, which they are now recognizing. Even though it was less reactogenic, it was also less effective than the whole cell pertussis vaccine.
Last question from Chandni. How can we make the HPV vaccine for women available and affordable in rural areas when one dose costs Rs 3,600? Shouldn't the government interject?
I agree 100% with Chandni. I think the government has a responsibility to provide preventive care, and providing all the vaccines that can prevent diseases that are important to us is part of their role. They should be providing women with the vaccine. As I said, in Punjab, it has already been introduced. The other states should also be introducing this vaccine. We should have this available across the country for girls. For boys, it is a vaccine that is recommended in the West. The data is less clear about how much value it would have for cervical cancer in India. It would certainly have an effect on anal cancer and on warts, but a big public health problem is cervical cancer, and giving HPV to girls would help us control that.